to introducing our speaker. All right, so at this time now, I'll be introducing David Love. David is a licensed marriage and family therapist, and he is also the founder and executive director of Valley Community Counseling Services located in San Joaquin County. He brings 40 years of experience working with families and children impacted by domestic violence, child abuse, and/or substance abuse. He has provided training both nationally and internationally, providing services to the United States while also presenting in Europe, China, Japan, New Zealand, and Australia. His most recent book is titled After the Fact, a guide for families learning of their child's sexual abuse later. Please join me in welcoming David Love as our symposium speaker.
Hi, everybody. How are you doing? Well, we'll do all the technical stuff here and get us up and running. Let's see. Why? Somehow I'm blocked a little bit here. There we go. That looks good. Welcome, everybody. I see from our little queue there, we're up to about 97 people who have joined us. We're really excited about that opportunity. I'd have to share my only chagrin is that I'd much rather be sitting in a room with everybody doing a conference and counseling. I love doing that kind of stuff. Hopefully, we're going to get back into that. I just got a notice from ABSAC that they're going to do their first in-person conference in December, hopefully. So slowly we'll be moving back to that format. I think this format will stay with us though. I think there are ways, and I don't know about you, but for me to take the whole day off and go to a training, there are times in which it's a challenge. And if I can do an hour and a half or 2 hours and do it with folks, we did a training a while ago, national training. We thought it was national, but we had 22 nations logged on to the training. So that's an exciting opportunity for all of us. I'd like to thank Melissa and the whole team for putting this together. They've done an awful lot of work behind the scenes to make this really work. So I thank all of you who were involved in that. I think it's an important thing. When we first started talking about doing this little seminar, I always have the first question, who the heck's going to attend, so I can say something that's relevant to the people that are there. So I'm doing what I call hit the middle. It's not a basic course, and I also have taught TFCBT and other things where we spent 4 straight days doing strategies and practicing and role playing. So we're kind of in the middle. I hope you will take some of these ideas here and follow them up. My last slide will be a whole bunch of websites where you can get free training, where you can get information, where you can download data. We'll never stop learning in this field. I think that's one of the most exciting things about it. I've done it a few years, and I know that every year I learn more. And that makes me better and much more skilled at doing this. I first started in this field. I started a child abuse program in San Joaquin County in 1977. We were the first in the county and one of the first in the state. I was in court yesterday, actually in Fresno, testifying as an expert witness. And I had the question, well, how did you get into this and what motivated you to do it? In the mid 70s, we really strengthened the mandated reporting laws in the state of California. And we expanded from about 10 people to almost 50 people, the number of mandated reporters. And when we started adding school teachers and doctors and ministers and rabbis and drug and alcohol counselors, which interesting, were one of the last group because we had to fight federal regulation. We had a conflict in laws. All of a sudden, our county, we were averaging about 35 sexual abuse reports a year. And within 3 years after those changes, we were averaging 30 a month. And we all know that about 1/3 of all young women will be molested or raped by the time she's 18. We know we're just missing tons of kids out there, but at least we've evolved so far that we're getting a grasp of it. Now, what the heck do we do with it? In my experience, at least, I think child sexual abuse treatment is one of the most difficult things a therapist will ever do. for multiple reasons. First of all, it's very complicated, it's complex. We're talking about family systems, we're talking about cultural values, we're talking about community beliefs. And as we learn more and more about the impact of trauma on the brain and development, we're dealing with something that is much more sophisticated than anybody ever guessed, which puts on us who are doing work in the field extra responsibility. And added to that, this affects us. You can't work in the child sexual abuse field and not feel it yourself and emotionally relate to it. As a program director or clinical supervisor, I constantly feel I have to look out for our team and how they're doing. I have some new, young, really energetic therapists joining, and all of a sudden they want to work with child sexual abuse. And my answer is, you can't do just that. You need to have a little sort of broad section of what you do, or it's going to take you down. And when I see my staff talking about they won't let their kids go to camp anymore and they won't let them go play soccer because they're worried about them getting molested there, I know that we need to sit down and have some long conversations and work with them. And I think that's a good field test for everybody. So I think we got to take care of ourselves. And I really want to emphasize that. I talked to Melissa and the team when we sort of did our preview of this, and I said, I'd like to start with an activity. If we were all sitting in the room, I'd be doing this activity. So I'd rather try it online and see how we all do. Now, I'm a huge fan of mindfulness, and just like mindfulness. I don't think it's an intensive therapeutic process, but I think it's a great ancillary process that's so essential. Dr. David Lasik at Massachusetts did all kinds of studying on trauma in the brain. And one of the things that became very important out of his research is we're pumping out huge levels of cortisol into our brain every time we're under stress. I tried to explain that to a jury yesterday, that kids have problem with recall and memory and remembering what happened to them because the way their memory gets encoded is compromised by all the stress hormones in their brain. Well, that affects you and I. I don't know about you, but after many years, still when I walk into a session that I know it's going to be a little difficult, we need to work really hard, I have a little anxiety about it. We did a research project a couple of years ago. We trained 6,000 teachers on how to do mindfulness so that when the kids arrived in class every day, they would do a mindfulness activity before they started teaching. I had teachers say, well, I don't have time for that. I said, it's 3 minutes. That's all I'm asking, is 3 minutes. But I guarantee you the research is so strong, this hard research, that your kids are going to remember what you are teaching them at a much higher level. They're going to perform much more level. Your behavioral problems are going to be lessened. Give it a try. So we asked them to do this in the morning after break in the elementary school recess and after lunch, etc. You can do mindfulness, you can do meditation, you can do yoga. All of these things really have a lot in similarity. They lower cortisol. They improve memory and recording and encoding. They improve cognitive performance and decision making. So let's do what I preach here. Let's all take our right hand, put it over our heart. Relax just a second. And I'm going to take you through a very short breathing activity before we start. So I'm going to ask you to do deep, slow inhalations and then slow exhalations. So we're going to do 3 sets of these. So we're going to begin and slowly now begin to inhale. Slowly, slowly, slowly. Stop. 1, 2, 3. Slowly exhale. Slowly, slowly. Stop. 1, 2, 3. Let's start again. 1, 2, 3, in. Stop. Exhale. 1, 2, 3. Stop. One more. Slowly inhale. 1, 2, 3. Stop. And 1 exhale. 1, 2, 3. Stop. Great. Thanks so much. Carry it on a little and maybe use it, give it a try, see how it goes. All right. I think there are a few statistics that are just important to quickly review. Depending on the research you see, this is Dr. Brown's work out of the Greater Bay Area. She found that 1 out of 6 boys and 1 out of 4 girls will be raped or molested by age 18. And I think these stats are partly wrong because she made a decision not to put anybody in the study that was in mental health treatment. So I think the numbers are high. Less than 30% will ever report in their entire life to do that. Dr. John Briere at University of Southern California, John did some really good studies looking at the disclosure of folks, found that 74% of molested kids haven't disclosed at the end of the first year, 50% after 5 years. I wrote this book with Dr. Derlin Anima, and we started looking at priest abuse in Stockton. We had one priest who had molested over 40 kids. And we were going to write the book about that, but we decided to expand it. But what we ended up doing, the average length of time from when the individuals we interviewed here, which were a large number, from the time they had been molested and disclosed till when they disclosed, was an average of 15 to 25 years. That's what we called it, after the fact. And now all of a sudden, here you are as a 20, 30, 40-year-old person, and you're telling your parents, other people in your life, your partners, you were molested. It's a huge issue. And I think we need to understand that. I remember when I was young, I used to see ads on TV for stranger danger. I used to joke, don't take jelly beans from the dirty old man in the park. They're not who molests kids. Who molests kids? Brothers and uncles and aunts and Boy Scout leaders and teachers and coaches and priests and rabbis and mullahs. They're people who have an existing relationship with kids, which means the trauma of being molested by someone who should be caring for you, who you actually probably respect or love, is horrific violation. That's why the trauma grows. And if we look around, where does molest happen? Well, the majority happens at home or in a place that should be safe and where you go. The other thing that I think is important, I did a large research and treatment project with juvenile male sex offenders. And one of the things that became important, we know that 25% of all kids who are molested are probably male, but when you look at CPS data, it's about 5%. So we're even more in a problem of underreporting male victims. And it's something I think we need to do a lot of work with. And I think therapy with male victims have some nuances to it that are different than therapy with young women. And I think it's a part of things that proves our ability as we understand those nuances. So general overview, what are we doing here? We do evaluations, we do assessments. We know what's going on. I'm sorry, but I think I need some really well-structured assessment tools to give me a grounding, to see what they say about what's happening here, what they see in the trauma, what they see in what the person's bringing to the table, in addition to what I feel when I'm doing a clinical interview. It gives us much more broad base. As a clinical supervisor, I would always ask, okay, the assessment said this, you say that. Let's talk about the differences and the perceptions and what they mean as we develop a treatment plan. Because of the way the system's structured, most of the work we do is individual therapy. I'm not sure it's always the best to only do individual, but it has a tendency to be what we do. The biggest challenge I see as a chat agency, most of us see across the state, is how the heck do we get families involved? It's been interesting now, basically being online for 18 plus months, have a little better success of engaging some caretakers because we're in their home. It's like doing a home visitation. I love home visitation. I think it's so important and it's so hard to facilitate, get done. I've run 2 or 3 programs where we did a lot of it, and every staff member who was new to it was scared to death to go out to somebody's home. So we do it in partners and pairs. But when you walk into a home and spend an hour there, you learn more than you probably have at 18 sessions asking them, how's it going? Because you see it all. One of my instructors years ago, much to my luck, was a woman by the name of Virginia Satir, one of the founders of family therapy. And Virginia believed that when you did family therapy, everybody was in the room, meaning the baby was in the room, all the kids were in the room, grandma was in the room if she lived in the house, and that's how she did family therapy. I asked her once in a training as a student, I said, well, what about the baby crying? She said, when the baby stops crying, you can feel like you're doing good work because the baby feels safe enough and comfortable enough to go to sleep. But if the baby is always agitated, there's something going on here, and you should pay attention to it. Interesting perspective. We do much more sterile family therapy normally. We have 1 or 2 caretakers come to our office. It's a different modality. I'm very lucky, and I think it's something more of you are doing, and I think it's great, is actually putting our staff on the school campus. Got tons of kids that won't ever get to a clinic, but I can see them on campus. I get to talk to a teacher. I work with the school counselors. We work in partnership to develop a behavioral plan. So we have ideally we have family therapy going on. We have behavioral plans going on at school. We're probably doing individual work. And then the last piece is we've got to be really open. There are mental health diagnoses without medication don't improve. I got extremely clinically depressed kids. I like to keep them alive because clinical depression puts them at extreme high risk of suicide. So it's something we really have to be careful about. So we need to know that. And if you have some way of interacting with someone like that, it's just so much better for you. So assessment tools. These are some tools that are well researched. Most of them, some are on SAMHSA's list as models. I think the parent stress index is really helpful. We're working with families. How are they doing? What's going on with them? I think it has a double layer to it. Gives you lots of good information, but we're asking them, how are you doing? And I think they really appreciate that. I think they feel like somehow or another, they're being blamed at times for why their kid's having a problem. An awful lot of preteens and teens have some pretty significant self-medicating drug and alcohol related behaviors. I think first of all, to define to schools, to parents, to everybody else, when we have a traumatized child using drugs and alcohol, they're not a bad kid doing stupid stuff. They're a child doing stuff that makes total sense. They're self-medicating a lot of their emotional and functional pain. This is a really good tool to evaluate that. There's actually an electronic version you can put on a laptop and have the young people take it independently of you and the agency and get the results, and then you can discuss it and cover it with them. Dr. John Briere at USC, who's one of our key colleagues in our field, developed what was called the Trauma Symptom Checklist for Children, and then developed a second version of it for younger kids. So there are 2 versions of this depending on the age of the children. I want to talk about this in a little bit more detail. I think it's one of the strongest tools we have overall for looking at trauma in kids and child abuse in kids, what's going on. The nice thing, it feeds nicely into a treatment plan, gives you lots of data you can incorporate in your treatment plan. If I were a supervisor and I was reading a treatment plan and I look at the results of the TSCC and I don't see anything from the TSCC in the treatment plan, my first question would be to the clinician, hey, what about this stuff? Have you thought about this? Are you using this? You're not, tell me why you're not using this information. Kids act out a lot when they're traumatized and when they're molested. They get in trouble at school. The number 1 referral we get with our therapist on campus is kid got in trouble. And so the first question ought to be, why? What's going on here? This is a helpful thing. We're looking at actually a new project that we think will start in the fall. I have permission from a school district to do it, and I'm working with the ACEs Academy here in California on this, and APSAC. There's an instrument called PEARLS, Pediatric ACEs and Related Life Events Screener. Again, I want to talk about this in a little bit more detail, but there's certainly strong evidence that when we better understand young people's ACEs that already exist at age 8 or 12 or 15, it gives us insight into what they're bringing forward and how we deal with this. Did an interesting research project where we gave what's called the TESI to 6,000 students in the public schools and 8 school districts in San Joaquin County. And we were looking for kids who had trauma histories. And we were particularly interested in kids who necessarily didn't present, weren't in counseling or therapy at all yet, but had trauma histories. Nice thing about this, you can do it really quickly. It's a very short screener. And then we selected from that the kids with the highest scores, and we provided TFCBT to 1,500 of them in the public school system. And I think that the number of child abuse cases we surfaced through that number of CPS reports we made was huge. And it really gave us an insight of what we were missing and maybe another way to reach that population and do a really nice hand-in-hand relationship partnership with school districts. It's really a good way to partner. So then we also want to take a look at what things can do. So let's talk about the TFCC for just a second. It's a self-report measure of post-traumatic distress. The one for older kids can be usually filled out by the student, by the young person, kids 8 through 16. It's a developmental question. I've seen 8 and 9-year-olds who can't do it, and I've seen 7 and 8-year-olds do a great job of it. John developed the one for younger kids then, but that has to be filled out by a caretaker. An interesting thing you might consider trying is have a parent fill out this with a 8 through 16-year-old, and then have the young person fill out independently of each other, and then look at the results. And it's really interesting when you have got discrepancies and they see the world differently, and the parent describes the child differently than the adult. As an adult, then the child describes themselves. It gives you another whole in-depth insight, and certainly helps you build treatment plans that are more comprehensive. Nice thing about this instrument, it was normed across huge range of racial and social economic backgrounds. So in California here, it's a good instrument because we are such a wonderfully diverse state, and that gives us the opportunity, but have to be aware of cultural concerns and interests. The full version is 54 items, so it takes a little while to do it. There is an interesting version, a number of places that felt it was inappropriate or they were uncomfortable asking the sex questions that are in this. They did produce a version where some of the sex questions are removed. As a child sexual abuse therapist, I have a concern that now I have the questions that give me some of the most valuable data and I don't have it, but it is available for those places who feel uncomfortable using the full version. There are 2 validity scales in this. The under response scale, which means you're faking it. You're not talking about stuff that's uncomfortable. And both in the adult filling it out or the child, what are they hiding, what's going on? You can see they're under responding by the way the scales work. And then you get what we call hyper response. One of the most common things in that is you have an adult who was molested themselves, lots of trauma, and they're projecting all this stuff on their kids. And that's an important thing to understand because it goes to the validity of what we're getting and how important it is to use and whether we're comfortable with it. And then it's wonderful as I develop a treatment plan. It's got an anxiety scale, clinical depression scale, anger and aggressive and acting out, looking at post-traumatic stress, PTSD issues, which all of you know when we're doing child abuse treatment. PTSD and clinical depression are right there at the top of the list of clinical concerns. For some of the kids that are highly traumatized, get a sort of a window into dissociation, which is something we see. Whenever I worked with a child who was fully dissociated, actually, interestingly, believe it or not, had a handful of kids who had full-blown multiple personalities, really interesting looking kids, interesting clinical work, but obviously a symptom of great concern and trauma. And then their sexual concerns and issues, and all of those things go together. So now we're getting some good baselines. So once we've got 2 or more instruments that we're using, then what do? Well, we do a clinical interview. You may do it parallel, you may do it simultaneously. I think because PTSD is such a high probable issue that you've got to be looking for PTSD symptoms and noting them and keeping it down and working with that as you go along. We're all fully cognizant of the fact that we've got to do open-ended general questions. We just have to keep reminding ourselves of that. If you're new to the field, practicing this with others is really important. I think it's a great thing to do in clinical supervision groups till people are really comfortable with the process of doing this. So what we do in our clinical interview is we establish this baseline of distress, knowing what's going on. Much as in TFCBT, which we'll talk about in a second, I like just having them tell the story with really not doing much intervention. The more they talk and the less I do, the more I'm really getting this unfettered picture of what's going on, and it helps me see it much more clearly. A number of years ago, I took a 2-day intensive forensics interviewing class, not wanting to be a forensics interviewer, not the full certification program, but boy, did I get better at asking questions and asking much more careful questions which were less contaminating. A number of years ago, we talked our local DA's office into letting us see kids in therapy before they had gone to trial. And that was a big ask. And I know in each county it's played out differently, but I had to make them understand and convince them and trust me that we weren't going to contaminate their case when they went to court, because we can do things in a therapy and questions we ask of kids that put their case at risk in the courtroom. But on the other hand, if we are doing mindfulness and we're getting kids much more comfortable and feeling better about themselves and those things, they do so much better in the courtroom. And they're already beginning a healing process without compromising the forensics and courtroom environment and situation. So something to at least give consideration to. I think that I push this, so you have to deal with my own particular biases here. When I have an opportunity to do evidence-based therapy, particularly with something as crucial as child abuse treatment, I really want to start there. I'm not saying there aren't other techniques and strategies and things out there that may have great value and can be used in consort and parallel. We don't always do one thing. When I first saw PCIT, we worked very closely almost 30 years ago with UC Davis Care Center, Dr. Anthony Arqueza. And we said, this is cool. I think this will be really helpful. If you haven't seen PCIT, I'll give you the website and you actually can see some little demos of it. But this is in its full-blown use. You have a one-way mirrored room, you have video recording, you have audio recording, you have cameras and all the gear all set up. And it really has great research outcomes when used in its entirety. It has a couple problems. My room cost $50,000. I was one of those lucky people that I got a grant from the state to build my $50,000 room. Hopefully talking to all you nice folks at OAS and other places, if we can get money to help other people build some PCIT rooms, I think they're fabulous. We're doing PCIT without the rooms also, but I think the rooms have some real advantage. We also use the room not just for PCIT. We can do clinical observation through the one-way mirror. I love kids though in the one-way mirror. We have this very expensive camera up in the corner, and I discovered after 3 weeks, the average traumatized child can hit the camera 4 out of 6 times with the building blocks. They're winging it at the camera. So we had to go back and put plexiglass all around our camera so kids didn't take the camera out, kind of thing. We use a strategy sometimes where we actually have the parent leave the child in the room. We had a child that was screaming and yelling and pounding on the floor, and mom couldn't get him to function. Now, mom's got a bug in her ear, so we're talking to mom the whole time. So we say, Mom, and there's only one way out of the room for this child because the other door we have to open, but it's back where mom. So I said, Mom, why don't you come in here for a little while? Oh, I can't leave him. I said, yeah, you really can, because you can see him. And so mom finally begrudgingly comes in where we were with our in the therapy side of the mirror, and he's pounding on the floor and just going crazy. And starts slowing down, and he eyeballs the mirror, kind of looks up. He knows where we are. And she said, what am I going to do? I said, we're going to let him get bored. And sure enough, he calms down, and he can't laying on the floor. And we got some really cool things sitting on the table there. So he gets up, gets in the chair, starts working with the table. And I said, Mom, now you go back. That's a really cool environment. We are using actually iPads in 2 different rooms to deal with some of our outlying offices or in other places. So there are other methods. When they took this to Alaska, there was no way of setting up one-way mirrored rooms throughout the villages in Alaska, but there are other electronic stuff. Now, since there's such cool things in this, UC Davis has developed a program called PC Cares. And PC Care is a modification of PCIT with all the fancy gear, but it carries a lot of the same sort of important clinical designs in it. So again, my staff member who went through the PC Care training really liked it. She was already a PCIT therapist. And so these are 2 areas that I would certainly think about as modalities within your agency, depending on your resources and that, but it's really good. When Cohen Manarino, et cetera, which I'm going to talk more about them, developed TFCBT, I was lucky we went through their pilot training program they did multiple years ago. And they brought a number of us together and said, what do you think of this? We said, we like it, but I was a kind of a CBT therapist already before we did this, so it made sense to me. For some people, CBT seems a little structured and organized and really focused. It is, but it certainly has some assets to it. If you've never had training from Eliana Gill, her trauma-focused play therapy, her books or trainings or information, Eliana was actually with me and a group of people on the first Child Abuse Prevention Coordinating Council in the state of California, and we really tried to get training going. Look at Eliana's work, and when training starts back, or she's got an online thing, if you've never seen it, it's worth it to you. And then I really recommend getting trained in mindfulness, yoga, other related kinds of issues. We got in huge trouble in schools about 2 years ago, though. We introduced mindfulness and yoga, and we had a large group of people come to the school board screaming and yelling that we were using yoga and we were teaching their kids Eastern religion. So I got smart in a hurry. We don't call it mindfulness and yoga anymore. It's just mindfulness. Even though if I look at the activities and things we're using, they look awful similar. But you've got to be politically wise as we all work in our communities. So when Cohen Manarino and Deblinger decided to put together a really focused process, and their trainings are wonderful, and there's videos of their trainings, and you can see them actually working with kids in the trainings. And UC Davis has some certified trainers there, and other places have them throughout the state. Why am I saying that? I'm going to use this as an example of a research-based thing and why it's so important, I think. And a part of that, move you guys. I can move you guys. I moved your picture so I can see my whole screen. The psychoeducation component of this, people don't understand child sexual abuse. They don't understand why the kids are doing this. They view it as acting out and defiant behaviors, and it's really confusing for people. So the psychoeducation first component, which means we have to be pretty knowledgeable on human sexuality, child sexuality, and abuse dynamics, because the questions will come really fast and furious if you really get this wrong, and for the kids. It's based on the concept we have to process trauma. Parents say over and over again, well, I don't know if we should talk about this, because if they don't talk about it, maybe they'll feel better. And it's hard to explain. Without talking about it, it's not going to probably get better. And we got to go through the painful process before we get to the healing process. And that's a little hard to educate people in. And that's one of the big tasks I would have over and over again. So when we think about it, we're teaching by practice and behaviors, homework and activities, adaptive thoughts that are more functional. We've got tons of cognitive dissonance going on in child sexual abuse all the time. A lot of emotional problems. Some of the new good research shows that kids who are sexually molested or traumatized at young ages, the empathy center of the brain doesn't grow properly, literally doesn't grow. So that means all of a sudden we've got preteens and teens doing horribly hurtful things to others. I've got 7 and 8 year old kids killing pets. and doing torturing animals and all those things at the extreme end, I agree, but obviously the empathy is not working there at all. Cool news is the empathy center of the brain can be healed or created or grow or really become a part of a child's life, but it's not a 3-day therapy process. It's over time. And I kind of keep that in mind, that that's one of the things I'm working on. And obviously everybody's concerned about behaviors. And so behaviors are really a cool, important issue that we need to take a look at. And then what are we going to do? We're going to develop coping skills. We're going to have them practice skills. We're going to have them do homework skills. And then we want safety. There are too many molested children who get molested again. So boyfriend A molests the child, and lo and behold, 2 years later, boyfriend B is now molesting the same child. I had clients that were molested by 4 separate people in the same family system. So obviously the safety of that family system didn't get modified in a way that's so crucial. So I think that's a part of our role, and that's why I like the family interaction wherever we get it, the caretaker interaction. You all know that we have tons of children being raised by aunts and uncles and grandmas and grandpas and all kinds of other folks. I like that. I think kinder care is wonderful over the having to then reach out to the foster care system. Not that it's not a great safety net, but boy, I like kinder care when it works. I think it's a really good model for us. So what do we do with CBT, with TFCBT? Well, we do CBT. We deal with the PTSD that's there. We deal with the clinical depression that's there. And to have dual diagnosis in the field of child abuse is more common than not. So we are working on a couple different tracks. Now, the schools and the parents and everybody else are highly motivated for us to deal with disruptive behaviors. And it's important. Kids are getting in trouble. They're getting hurt. They may be hurting other people. When I look at bullies, we've been running a program where we ask school districts for every bully to get a full mental health assessment, the bully to get the full mental health assessment. And when you do it, it's pretty clear why the heck this behavior is going on. But without interventions and new learnings and some CBT, you aren't going to change bullies' behavior in a significant manner now, or sad to say, later in life. They may show up in your anger management or your domestic violence offenders groups in another 5-10 years. And that's a sad and scary possibility. And then we deal with emotional disabilities, difficult. So here we are with the caretakers, with the parents, with the folks that we're working with on this. We want to increase support for them. We want them to feel supported. We want them to feel more empowered. We want them to feel more in control. We want them to feel more comfortable in talking about communication. You know, as a male, I'll admit to talking about feelings isn't my greatest forte all the time. And I don't know if that's a sexist comment or not, but I think we're somewhat of a handicapped group of people. So when I'm working with dads and male caretakers and that, I used to joke with them. I'd say, do you ever talk about feelings? Yeah. What do you say? I'm pissed off. Oh my goodness. I call it the John Wayne theory. I mean, a lot of you don't even know who John Wayne is, but oh, I'm okay. Good. That's great. No, we'd like a little more communication than that in our process. And then we're trying to lower their distress. They are distressed to the wall. Can you just, if it hasn't happened to you, imagine your child coming forward and telling you they've been molested. It's difficult. I did a court case last week in Fresno where the child told mom 3 separate times that her stepdad was molesting her, and mom said, "Oh, you don't know what you're talking about. That really can't be true." Well, he was paying the rent and he was putting food on the table, and he was an important person in her life. She emailed her teacher that she was being molested. And I got to say, great things for the teacher. She went immediately to the vice principal. They immediately activated counselors. They immediately called CPS. And that's how we ended up in court. I'm happy to say it was convicted on all 4 counts. We just got the results back yesterday. And we're moving forward. And I hope it's one moving forward in her healing process that goes on. But we just can't lose sight of those potential dynamics when we're working as a therapist in the field. So the big bang here is the Fed, SAMHSA, took a look at this stuff and did a really strong research on how well does this work. 63% reduction in child's PTSD symptoms, 41% reduction in levels of clinical depression, 23% reduction in the acting out behaviors. And they followed these kids for 2 years, and it sticks. It works in the long run. So if I'm going to spend 6 months to a year doing an intense therapy with a child with lots of stuff going on, I'd really like to be doing something I think is going to help. It's going to make a big difference. So that's exactly why I'm sort of touting this as a model. You know, it'll take you a little while to get trained in it if you haven't done it. It takes some while to get some practice and supervised experiences, and they're actually available through a couple different sort of places to get these kind of training and this kind of supervision, a lot of it online. But I'm just going to hype it. I took this into the public schools, and it was interesting. When we found those 1,500 traumatized kids, I wanted to do TFCBT, but we really made the decision. A part of TFCBT is what's called the trauma narrative. And what you do is you have the kids write down or record or video the full story of their most traumatizing molest experience they ever had. So they actually tell the whole story in depth. And it often takes weeks to do it because they leave parts out and you have them go back and practice it more, add to it. They remember more things. They get triggered by the process. So that gets more information on the table. And it was interesting. I got this funding partly through my county mental health system to fund this project. And I had 3 or 4 people over there say, well, David, if you don't do the narrative, you aren't having fidelity to the model. And I don't think we'll be willing to fund you to do it in that way, unless you can prove otherwise. Well, lucky I've worked in the field. So I called up, I talked to Anthony Arceza and Tony Marino developed at Arceza at UC Davis. And I had, hey folks, I'm thinking about doing this. And they said, that's an interesting idea. I like it. I think it would make some sense. I said, will you write me a letter so I can give it to my funding source and tell them that the people who designed this program approve it? So I think then they'll approve it. And we did it. Why do you do it not on campus? Kids after the session sometimes are pretty distressed because they're looking at tough stuff. Eventually they will show this to their caretakers and share it with their caretakers. But I think it's a healing experience when they're ready to do it. It's not the thing you do in the first month or 2 usually of the therapy process. Good for 4 through 18-year-olds, 5 symptoms of any of the 3 clusters of PTSD, history of trauma. And it's really nice when you do this if you can have somewhat of a stable placement. It can be foster care, it can be lots of other kinder care. But by having that kind of stuff, we end up, because we want the caretakers involved in the process. So if the kids are floating around and the people they're with have really no real interest in participating in any of the process, it's a lot harder to do and you're missing part of it. I'm not saying it's impossible, but it's the ideal focus. So what the heck are we doing at all in this field at all? 2 or 3 studies have kind of developed this list. And so I say, when we're developing a treatment plan, we're doing assessments, when we're doing clinical interviews, and sort of a caveat here, I would do an assessment again after 30 to 60 days, and I would redo my clinical interview almost again, because when you first start, they don't trust you, they don't know who you are, they underreport, they fabricate. I'm sorry, that's a difficult thing that you're asking people to do. So you're going to get all kinds of new information and they begin to trust you. Hopefully you've built some sort of a clinical relationship by that time. So I dig back in there again. I think it can have some real value. So when I'm looking at a child who's been sexually molested, we'll see, we're looking for, has their social competence, their ability to get along with others? Are they isolates? Are they outsiders from mostly at school? Are they in this very small clique of isolated kids? Now, there's a part of that that always goes on. We've been working with schools recently with what we call mean girl groups, part of the bullying dynamic. And here you have a group, often preteen girls, who each week they pick out their new victim. that they're going to go after. Now, what's going on in the heads of kids that every day going to school, their modus operandi and their desire is to be totally horrible to other human beings. That's a social competence problem, I'm sorry. And those are the kind of things we're talking about. Normally, if you look at academic performance pre and post molest, you see what happens to them academically. It's really excited to see kids' grades come back up, beginning to enjoy school as the therapeutic process. Good measure of some of the value of what we're doing is how are they doing at school? How do they feel about themselves? How many kids walk into treatment and say, I hate myself, I'm a terrible person, I'm ugly, I'm a bad person. Partly the offender has talked them into that, part of the grooming process, but the self-esteem issues, how do we help? Families get torn apart by this, or at least damaged in big ways. Realizing there's huge concerns about standardized IQ tests, but when they did some of the studies, they went down. It said something's going on here. And one of the big concerns we have is teen pregnancy. Kids involved in self-destructive sexual interactions. And we know that the age of voluntary intercourse, which they view as voluntary, they picked out somebody they choose to go to bed with, goes way down when kids are molested. And so helping kids then deal with their sexuality, their choices around sexuality, when clearly they're struggling with it, is really helpful for us to understanding where we're going in treatment. I don't know about you, but substance abuse and molested kids. My youngest alcoholic was 8 years of age. He got caught at school. He stole vodka at home, and if anybody knows how to get alcohol at home when you were young, you learned this maybe. Took mom's vodka and he would pour vodka out to take to school, and then he put water back in her vodka thing and he'd see where it was so she couldn't tell the vodka was disappearing, and then he put orange juice in it and he came to school. We got a referral from a teacher that said, I got a student that throws up a lot. I said, well, have you sent him to the nurse? Yeah. Nurse couldn't see anything, and they actually got a note back from the doctor. And so I asked her this question. She thought I was really bizarre. I said, what does he throw up? She said, what do you mean? Well, he's throwing up on the floor. What does it look like? She says, orange juice. I said, okay, thank you. That's what I wanted to know. So kids all had backpacks in the school. So I met with the young man. He had his backpack in. And I said, how are you? And fine. I said, understand you're sick a little bit. Yeah. I said, are you willing to tell me a little about what's going on? Well, sometimes I don't feel well. I said, do you have anything to eat before you come to school in the morning? Sometimes a little. I said, any juice or anything? Yeah. I said, do you bring your orange juice with you to school? Why did you ask me that? I said, well, I was just curious. Do you have your orange juice in your backpack? Yeah. And I whipped out a cup that I just happened to bring with me. And I said, can I have a taste? No. He wasn't a dumb kid. Why vodka? Doesn't smell. But I'm sorry, if a kid drinks vodka and orange juice every day, he's got a serious alcohol problem. He's self-medicating. Now I want to know what he's self-medicating. And off we go as a therapist. And I think that's really important as we look at those things. And of course, we have been lucky in working with really wonderful schools where they don't kick kids out of school necessarily in that environment. You get caught drinking in school, what happens? You're out of here for 2 weeks, which then I lose access to the child if I can't get them into counseling. And so we asked for sort of delayed expulsion or in lieu of counseling, in lieu of some sort of punishment. And I think schools are getting really good about this. And I think they are really getting more and more on top of it. So I give them a lot of credit for that. Problem is a lot of sexual acting out behavior. How many young people truly enjoy the sex they're having? I'm sorry, how many? Why do they have sex? Well, it's a whole bunch of different reasons. Someone likes me, someone pays attention to me, I get good things. I feel like I'm important, I'm desired. That's really good things to feel, but there might be another way to get there. And so I need to talk about it and address those kind of things. We were able to do a very large program where we were working with basically kids in 6th through 10th grade It was under the guise of a pregnancy prevention program because that's the money I could get. But we were doing small groups, and we were looking at, we did sex education, and we did information, and we talked about behaviors, and we talked about family plan, birth control, we talked about STIs and STCs. We got it all in these small groups that were really good until I got almost thrown out. We had an all-female group with a female group leader, and she started talking about STIs, and she said, you know, you can get an STI from oral sex. And the whole room went exactly stone cold quiet. And this was 7th graders. And she said, what's going on here? And then they started laughing and giggling. And they said, are you sure about that? She said, I'm really sure about that. That's really true. Well, she said, well, we're having a contest right now, and we were a little concerned about that. What's the contest? Well, the contest is how many guys can we have oral sex with in the next month? See who's the winner. Well, one of the girls went home and said to her parents, we talked about oral sex at school today, and we had parents in busloads headed for school, I think, that we were talking about oral sex, and they thought it was totally outrageous that we would even talk about oral sex in a group, even though we had kids having contests to see how many guys they could have oral sex with. So all of this gets really interesting, but when we as a therapist see it from our side, we see it as a really important clinical question. We know they get involved with delinquency, with aggressivity. Kids, when they don't feel good about themselves, you do a lot of things. And one of the things you do, you eat to feel better, and you eat a lot to feel better. It's a big concern. Dr. Vincent Folletti, who designed the Adverse Childhood Experience whole program of research, was working in an obesity clinic with extremely obese people at San Diego. And that's how this research even got started. We know that teen pregnancy rates of traumatized and molested kids go up significantly. And if we're going to ever have a teen pregnancy reduction program that works, we're going to have to do with therapy and counseling and evaluation, or it doesn't make any sense. My last current is suicide. I don't know how you guys are doing out there. We're just constantly concerned about this process. This area we serve, we've had 10 completed suicides in the last 9 months. Average age 14, had 2 12-year-old foster young ladies hang themselves within 3 weeks of each other. 40 suicides in the last 3 years in K-12, in the area we serve. I'm really concerned about this, big time. And I want to get these kids before we're too late and we're having to do crisis teams and working. And now with online stuff, we had a young person kill themselves online during a class, and all the kids were online when he did it. So huge concern for us. And we know that traumatized, molested kids, et cetera, are so much more at risk for suicide and clinical depression. So now I got to make a diagnosis. Everybody thinks I should make a diagnosis. I agree with it. We should make a diagnosis. I like the concept of called rule out diagnosis. Many of you do it, but rather than saying, I wonder really if this person has PTSD, let me go down the process and see if they have PTSD, and I'll rule it out if it really doesn't exist, which gives me a lot more data. And it keeps me much more open-minded, I think, to the process. And some of you can take a look at that. So these are some diagnoses I think we should always rule out. And, it goes in your clinical notes. It's not a legitimate full diagnosis, a rule out diagnosis, but it's a legitimate clinical process. So I would always rule out PTSD. I would rule out complex PTSD. If you're not familiar with this, there's a number of good trainings that, again, that Dr. John Briere does about complex PTSD. You get on his website. There's actually some papers and stuff that you can get free to look at complex PTSD. When I teach about PTSD, I always teach about complex PTSD, and our sexually abused, traumatized kids are the most probable group of people to have complex PTSD because they got so much going on. It's just not one single element. I do a lot of therapy for soldiers. I'm a former military soldier myself. But if you got you're driving down the street in your Humvee and the Humvee in front of you blows up because it hit an IED, it's pretty straightforward what just happened to you. And not saying that the PTSD isn't really serious. But now if I have a soldier I'm working with who was molested as a child, who grew up in a domestic violence home, who had some alcohol problems before they went in the military, and then they have this problem in the military, we're not dealing with an IED just blowing up. We're dealing with a whole bunch of stuff coming together. And sad to say, we have 8, 9, 10, 12-year-old kids who have 3 or 4 things that they've already experienced in life that fits into the ACEs categories. And now it's much more complicated than just straightforward PTSD. We run 2 children's mental health clinics for the county mental health system as a contractor, and ADHD coming in the door. I think that every secretary at school can diagnose ADHD, and they all know that please give the kids the pills, because then they aren't such a problem. I had a joke the other day with some of my colleagues saying, I think we should set up a McDonald's style mental health clinic, because what parents really want is if they could drive their kid up to the window, have the kid open their name, hit them with a Ritalin, shut their mouth, take a drink of water, drive away. That's all they want to do. I said, you actually should come into the building, because parents say, I don't have time to come in for family therapy. I said, you know, if you really want us to help, really be good if you could come and spend some time with us here. And maybe we can work out a way for that to take place. But I have this fantasy is that's their ideal therapy process in some form or another. The dissociative disorders, the more prevalent than sometimes we believe, and since they're so complicated, some really understanding of them in a therapy design. I think one of the problems as we became therapists is that if I've got a diagnosis that might fit, but it's something I'm not highly familiar with or haven't seen before, I have a harder time making the diagnosis, and I'm not quite sure what to do with it. Of course, that's why we have clinical supervision to do those kind of things. Of course, the acting out, conduct disorders, getting in trouble with the law, all that good stuff, I should take a look at. So that's all those screenings you just did. You're going to get information about behaviors and what they've been doing, and that will feed you into this. And clinical depression. Actually, clinical depression, we're pretty darn successful with it, even with kids. Normally you need a combination of medication for a while. I think with ADHD, if kids aren't functioning well at home and or at school, I think partnering with whoever is someone available to you for medication and tracking together with them, I think it's a really good thing to take a look at. So I've got to tell parents what I'm going to do here, or I want to explain to the young person what I'm going to do with them. It's confusing. What's therapy all about? You're going to shrink me? I had a young lady who walked in many years ago and says, where's your couch? I said, what do you mean? She said, well, I have to lay on the couch to talk to you, don't I? I said, no, we don't kind of do it. We use a little different system here. I used to do a lot of work with methamphetamine users, and I had a rule. I sat by the door and they sat in the other room, because if I needed to leave the room and they went after me, I wanted out quick. So when I do therapy in a treatment process, I really look at the whole milieu. I look at my room. I look at safety for them. I look at safety for me. I think it's all part of the issue. So what are my goals? I want to explain to them how trauma relates to symptoms that they're experiencing. And as we've worked to this stage, we've got the symptoms more and more identified, behaviors, things they're feeling, things that they're doing, stuff that's going on, things their parents are angry about, all that good stuff, why they got kicked out of school last week. But we've got to do it in simple ways, no clinical jargon, a way to understand how this thing that happened to you relates to this thing that you're feeling, that relates to this thing that you're doing, relates to these things that we're going to try, and this thing can help you in this way. I still like whiteboards. I'm old school. So I can get up there and draw, put things on, use colored markers. And if you don't want to do that, other ways to do this, where you can do this. You obviously could do it on a pad, and you can share the pad between the two of you and show stuff. But I think that really helps totally putting things into context. And what the heck are we going to do? What am I going to try and do with you? What are we going to work on together? We're going to help you feel better. less anxious and upset about things all this time. You keep telling me I don't think it can get better. Well, you know what? Maybe it can. You want to deal with that hopelessness, and particularly with the parents. If the parents been dealing with this for years sometimes, which is true, kids' behaviors and things not going well, and don't feel like they can do anything. I always joke with people. I said, I don't know if I really need a counselor. And I said, you know what? If I needed heart surgery, I wouldn't do it myself. And I wouldn't go to a bartender to ask them to do my heart surgery either. I'd go to a professional. We counselors are actually professionals, and we've done some good learning, and we think we have some good tools and things we can do, and we can work together, and maybe you might find this of some value. Give it a try. I think we've had people that really found this to be really, really valuable. And so I think that sort of building that relationship, and we often have to keep reinforcing the relationship over and over again. Now, something I use, and if you're not familiar with it, I'd take a look at it and look at my resource at the end on the ACES Academy. I just did a training for them. And we're also going to start a new research project based on this. So I like to say to people, you know, when we are traumatized and when we have these things happen to us, they don't go away. Every negative emotion, every pain, fear, anger you've ever felt, good news, every love, is stored in your brain forever. Sits there in the amygdala, and you can trigger. I play music that from your high school year, I bet you'll remember things from high school and people you haven't thought about in years, like going back to the class reunion if you've ever tried that thing in your life. We can trigger feelings. When I smell turkey, I'm back at my grandma's house because I went to turkey dinner every Thanksgiving until I got out of high school at my grandma's house. Or menudo, if you go to your grandmother's house, or whatever the food is. It triggers feelings and emotions. They're all there. The bad stuff's there too. So when Folletti took a look at this group of people that was actually in the clinic where they were working at Kaiser, they wanted to say, what do these people have in common? There's something going on here. And what he found out was they had a whole list of childhood experiences that were really, really scary stuff. How scary? Well, if you had 6 adverse childhood events in your life, the chance that you were going to be a chronic current smoker went up 250%. If you had 4 ACEs, the chance you were going to become an alcoholic went up 500%. And I got kids already at 8 and 10 and 12 and 14 on the fast track. Why? Because they were traumatized. We look at clinical depression, it takes 4 ACEs. One of the things we're going to look at in a research project coming up is that if you have 4 ACEs, you'll have an 8-fold increase in pediatric suicide attempts. That tells us something that's really important. It tells us if you've already been molested, if you've had these things happen, if you've had these traumas, till you go through a healing process, the risk factors continue on, not just today, but for the rest of your life, if the healing process actually can be superly helpful. Oh, sorry, went too fast. So this is called population attributable risk. It means 65% of alcoholics can be attributed to childhood trauma. 50% of drug abuse can be attributed to trauma. 78% of injection drug users, we're talking now about heroin. We have a huge increase in heroin and use of other opiate-related drugs in our state. Methamphetamine hasn't gone away. We've just sort of refocused because we're living in a pandemic right now. And we're going to, so thing we have to totally take a look at. Cocaine certainly hasn't gone away. Those kind of things. And when you get into that family of drugs, injection is certainly sitting there on the horizon as something we've got to always think about and be concerned about. We know that when you're traumatized and have huge issues, it often leads to change in brain chemistry. Trauma is related to 75% of all depression. And we find that if you're clinically depressed, in the ACE study, at least 54% of all current depression we contribute right back to some form of trauma. It's probably higher. Long-term depression, which people will come to us as certainly as teens and young adults, It's a really difficult thing to treat. With meds and work, we still aren't as successful as we'd like to do. We also know that sexual assault, both on the offender side and others, has ACE correlates, and so does family violence. Now, this data is all wrong. It's underreported, because you got to think about what Folletti did. He took 17,000 people who are all being treated at Kaiser Permanente in San Diego. They are not a representative population of San Diego. They all had insurance. So what if we would go through San Diego again and poll everybody that doesn't have insurance, who lives throughout the entire community? The Folletti is very clear. I've asked them a number of times. This data would go up, and actually they're getting some funding to take this to a different level to look at it. So it's actually worse than this in every single way. So what are we saying to people? We're saying to people, if your child or if you have been molested, had an adverse childhood experience, you've had these kind of things going on in your life, it's going to disrupt your neural development. Empathy centers don't develop as well. Cognitive part of the brain doesn't develop as well. Emotional part of the brain doesn't develop as well. You suffer more in school. You can develop more mental health kinds of issues. So both the social, emotional, and cognitive part of your functioning gets compromised by this trauma. And until we have the opportunity for a healing process, TFCBT for one shows we can heal. We can take these traumas and move beyond them in very positive ways. We have to develop a comprehensive set of health, so we look at health risk behaviors that we're engaged in. That's why we talked about the smoking and the drugs and the eating and the exercise and all those kind of things that we know as therapists, we have to build into a therapy model with people. It's just not talk therapy. It's world, life, family, systems therapy. And I'm sorry, you get a lot more diseases and you get a lot more physical problems, and we all understand the hand-to-hand relationship between emotional distress and medical problems and medical complications, and you die earlier. It's just straightforward, and this research is so powerful. Now, why did I throw this in here? I threw this in here to say this therapy is important. Doing these things can really be helpful. I've got to find a way to sell this to people who don't have the passion we do for it, don't understand what we're having to offer here, don't understand that the commitment of time and energy will be paid back over time. But that's a hard thing. And I don't know about you, but I've had too many parents eventually pull their kids out of therapy. I don't have time to bring them anymore, and I don't know if I can do this. We see a fairly large number of kids ordered by the courts to come to therapy. Well, their attendance is really good. It's a CPS issue, it's a family reunification requirement, et cetera. But I know when that CPS hold is going to disappear, I'm facing a huge obstacle because the parents now going to pull their kids immediately when they are not required to come anymore. And I get concerned because we're doing good work. Kids want to come. So it's a thing that can't be ignored with what we do. I want to talk about this screening instrument called the PEARLS. It was developed by the Bay Area Research Consortium. It looks at toxic stress and health. Cool news, developed in the Bay Area, 17 languages. I looked at our school district here in I County. Kids in our district speak 14 languages. I can't even find enough translators. My staff speaks 10 languages, but some of them we don't use all the time either. Don't use German a lot. Boy, I could use more people who speak Farsi. And so all of those things become a part of it. There are 3 versions of the screening tool. There's one for kids 0 through 11. It starts pretty young. Obviously, caretakers got to fill the whole thing out. And then there's a version where the caretaker fills it out for 12 through 19-year-olds, and there's a version that the kids themselves fill it out. And again, I'm kind of a big advocate of having both things happen and comparing the differences and the results. I've gotten permission from a whole school district that we're going to start giving pearls to a large number of students. My hope is a few thousand before we're done, and we have the mechanism to do it. I've got 45 counselors on their campuses every week working with kids. So my team of 45 counselors will, that and the school counselors and others will administer the test. It's very short, easy to do. To get the parents in for our kids in K4, K5 is going to be a little more complicated. We're going to do something very different. We're going to try and figure out if this piece of information I just shared with you, if you have 4 or more ACEs, your risk of pediatric suicide goes through the ceiling. So can we give this instrument to a large number of kids? And then we're going to look at their trauma histories, which may lead into therapy and counseling and other things also. But can we pick them up before we see anything that gives us a hint that they may be becoming suicidal? I really want to get to kids that are at risk of suicide before they commit suicide. So it's an interesting concept. Don't know where it's going to go, but we don't learn new things unless we try and figure them out. And this is something we've been talking about for a while now and got all the permissions to do it, because you have to get, obviously, districts to allow you to do things like this. One of the things, Melissa, I have a question. Are you there? Can you talk to me for a sec?
Yes, I'm here.
What's my time frame look like?
You have about 15 minutes.
Okay, good. All right. Probably we'll have a little time for Q&A at the end. When we start working with families, and I know having CalIOS in the background here, we have this issue in my chat program. What can I do with offenders or not do with offenders, et cetera? But I'm a comprehensive agency also. But the question hits the table, are we ever going to do family reunification when we've got dad and stepdad and brother and sister? When you think about this, when you go down the list of child molestation in a family, we forget this little piece of data sometimes. What's the most common molest dynamic in a family? It's siblings. More siblings are molested by siblings than any other individual in the family system. When we ran this large juvenile sex offender treatment and research program, 50% of all the boys that I had in this treatment program, and it was actually residential 2 years in nature, had molested a person that they lived with in their family. Sisters, brothers, whether they were step or not. So that's the big risk factor. We forget about this. And when we think about reunification, if we've got an adolescent who's molested a child in the family, there's a high probability they're going to be reintegrated back into the family eventually. And certainly we do reunification at times with others based on certain criteria back into the family. And that presents us with a whole therapeutic set of challenges of helping this family be safe again, trust again, work again, deal with these violations of trust and issues. It's a huge set in a family dynamic system. But I've got to think about my caretaker. I mentioned the case I just did where mom absolutely would not support her daughter who reported that she was being molested. I'm sorry, caretakers get stuck between this choice. It's a choice they have to make, because most people, when you find out your children were molested, you care about. My priest molests were really interesting because outside of probably dad, the priest was the most honored, important person, trusted, and to believe that your priest, who you've had all this relationship with, molested your child is just horrendous thought to even contemplate. And I've been involved in a number of cases with priests. We have people lined up out the door as character witnesses coming in to testify them. Until this really blew up a few years ago in the media, people just couldn't even comprehend this as a concept because of the violation, because of the trust. Can't believe someone would violate this kind of trust. And I think that's important for us to understand. And it's a part of a therapeutic healing process for the non-offending caretaker to work through these sets of issues in the therapy. probably one-on-one therapy as well as family therapy, etc. We have a loss of financial and personal support. People pay the bills and they're there for you and they're your partner and you selected them and your life is surrounding these people. It's huge. And I think as a therapeutic challenge, we've got to give everybody credit, but we also can't be blind to the fact that these dynamics are important for ongoing safety and future work with everybody there. How many people have said in our therapy sessions, how stupid could I be? How did I not see this? How did I pick this person? How did I not know this was going on? I should have been there. I should have been there to protect. Now, it's a little easier for families when it's the Boy Scout leader and it's the soccer coach, even that those aren't easy either. But feeling your own personal embarrassment about your lack of being there and supporting and providing the support that's necessary, and feeling guilty about not being there, not doing the right things, not doing the protection, not doing those kind of things. I often say to families, how much do you discuss sexuality over the dinner table? Not a lot. So we're really remiss in our education of sexuality to our children. And again, so often I think our family education is don't get in the car with strangers and don't go to someone's house you don't know. It's not that be careful because your coach may molest you. What we want to say is come talk to us when any of these things happen, and you got to be very specific about it, what it is, what you want them to talk to you about, what you're asking them to look at. A number of years ago, the state funded a program in our public schools, and it was called Green Light, Red Light. And we went into schools and we talked about good touch and bad touch. We had some funny stories. We had a little boy in the 3rd grade who told his teacher that his mom took him to a person who touched him down there on his pee-pee. And she said, what? Well, what happened? Well, he took my pants off and he touched me and looked at me. Well, she took him to the doctor. So we have to stay in context. But on the other hand, we did some tracking when we ran this program, and we doubled the number of CPS reports that were credible by running this program in schools. Because we said to kids, these things shouldn't happen to you. This is not okay. These specifically are what we're talking about. You can tell your teacher, your parents, your counselor, if you have any questions about any of these kind of things. We had to do some teacher training and prep because a lot of kids asked the questions right there in the classroom, raised their hands and said, what about this? Kids have 0 filters in K-6, by the way, if you haven't figured that out, which is cool in some ways. And then trying to understand them, it's real cool. Parents freak out about kids' filters. In my pregnancy prevention program, I had a dad walk into my group, grab his daughter and haul her out of my group while the group was going on and said, she didn't have my permission. Mom didn't have my permission to have her come into this group. And I'm taking her now and I'm telling you she's never coming back and can't be in this group. And I'll sue the school district if it doesn't change. Not that I'm an overreactor, but I found that interesting. Obviously, in the long run, guess what dad was doing? He was molesting his daughter and he was afraid she was going to talk. Now, obviously, that wouldn't always be the situation. I'm not saying that, but lo and behold, old suspicious me wanted to track down what the heck was going on here. But I think that whole dynamic is important. So I think that can't overemphasize the importance of family therapy. I empathize with you big time. It's so hard to get started at time. I've had some really cool therapists do cool things, and I'm not saying you should or have to do these kind of things, but he was just so great. He called up dad and said, I need to meet with you for family therapy. He said, well, I can't do that. I work in the Bay Area from Stockton. So I get up and I have to leave the house at 7 a.m. to go to work, and I don't get home till 6 o'clock at night, and I can't do this. And he said, that's fine. He said, I can set you an appointment tomorrow at 6 a.m. in my office. We can meet for an hour, then you'll be able to leave for work on time, or you can come in after work if you'd like. Either way, that would be fine. But I can make time for you as long as I know you're certainly concerned about your kids and you want to really do the good things. And you've said that. So we'll just make this extra effort for a few days and we can get this done. And so he kind of agreed to the 6:30 p.m. appointment rather than the 6 a.m. appointment. But I just had to give all kinds of kudos to the therapist for being sort of very focused and creative and working with his family. We got to do it. That's what we do. We got to engage families. We got to find ways to do that. A lot of people think I'm really nutsy, and it's something you should just evaluate for yourself. I like doing family therapy in people's houses, but I was trained by for Satira, so I like the dog in the therapy session and the kids in the therapy session and everybody else. But we ask that they not have everybody wandering through the house, and it's nice to sort of, have that. But if you got everybody involved, then nobody's going to interfere with the therapy session. They all live together. Now, obviously, there's certain types of therapy we wouldn't do that way, and certain topics we wouldn't do that way. But got to find ways to engage in some form or another. Caretakers have to understand the developmental needs of their children. They didn't get that in school. They don't understand that. I'm sorry that the needs of a 5-year-old and an 8-year-old and a 12-year-old. The other thing we see in traumatized and sexually molested kids is they're developmentally delayed. They haven't had the normal developmental life experiences. They've been isolated, they've been victimized, they've been traumatized. So they're way behind. I'd like to look at kids that they have 3 ages. How many years and months since they were born? So you got the chronological age. Then you'll have their emotional age. Then you'll have their cognitive age. How can they do things in school? They're never synced totally. And sometimes they're way off. I love working with continuation high school kids, but they are so out of sync. If you want to hack into some company's computer system, go hire someone at a continuation high school. If you want a mural painted on the whole side of a building, go to a continuation high school. Their skill sets are amazing. But we often have kids and some of their academic stuff that they do is amazing. So cognitively, creatively, they got all kinds of skills, and emotionally, they're probably 14 years old. That's why they're in continuation high school to the large extent. You have these huge schisms. And our job in therapy is to help these schisms get sort of shrunk, but also understand to parents that developmental issues in your children are crucial. And the younger we are working with children, the more we can do that, the more they can catch up developmentally in all 3, so things get synced better. I'm sorry, abuse is a huge damaging thing. We've said it over and over again, but how do I communicate that in family therapy and family education to get them really involved? And there's a bottom line to this whole thing. We have to provide a safe environment for children. Somebody unmuted.
When he gets bigger, his car seat will have cup holders.
Somebody needs to unmute. Take a look, everybody. Remute. And so when we build our counseling goals, underpinning the whole world is safety. Can't ever put that away. And I've been doing family therapy that I will do a new CPS report, because what I discover in family therapy is there's all kinds of stuff that didn't get surfaced, or more victims or victimizers. And that's what they're afraid of when they come in, is that I'm going to report them to CPS. And I know that's a thing that keeps people at distance from us at times. And I won't and can't give up that responsibility. And I just have to get them more comfortable with the process. Whoops, sorry. So what do I want the non-offending caretakers to do when they're concerned whether we're dealing with an adult offender or a sibling offender? We want them to understand the issues of empathy. We want them to recognize appropriate emotions in their children. And if their children are having empathy problems, if they're hurting family pets, if they're really being abusive to other children in the family system, if they're destroying property, if they're fire setters, all these are huge red flags of an empathy problem. And our research showed very clearly, if I have a 14-year-old child who's a fire setter and mutilates animals, I can tell you he has or will molest children. Period. End of story. That clear was the research. And why? Well, I'm sorry, fire setters and animal mutilators don't have empathy. That part of the brain's not working right. It's a clinical issue, but I think parents need to understand what empathy is and how to make it work. It's tough for everybody, and I think for caretakers at time to take other people's perspective. You're kind of into your own egocentric place, and it's hard to see how your child is experiencing this and feeling this and dealing with these things. And then we go through cognitive distortions. Well, it wasn't really that bad, and he didn't really have intercourse with her, and we're dealing with DV all the time. Well, he never put me in the hospital. That's a cognitive distortion. No, folks, that's not okay. That's a really important issue. In family systems, to live in our culture, our time, our place, it takes social skills. And social skills can be learned and practiced and done with, but inadequate social skills are a huge issue. Poor peer relationships are something we're concerned about, and social isolation in kids. Now, I want to talk just a tad about offenders, realizing it's a minuscule part of what we're doing. We understand motivation of offenders. They will go and do anything to get access to kids if they're motivated to molest a child. And this is not an impulsive act. This is not grabbing someone one day and molesting them. This is usually a series of events over an extended period of time that gets to most of the child sexual molestation we work with. So they need to find access, and they got to keep a child in a place where they won't disclose. So they use coercion, they manipulate, they get children to cooperate. They use threats. I'll hurt you, I'll hurt your mom, I'll hurt your pets. I'll take you to Disneyland, I'll buy you cool stuff, I'll get you a new bike. They pay attention to kids, and kids like attention, and they lie through their teeth. And we call this grooming. And all molest usually is inappropriate touching and playing and wrestling, maybe helping in a tub, then accidentally or a little bit putting hand under our clothing. Remembering we have a lot of molested kids in treatment that never had oral, anal, or vaginal sex. Doesn't mean they weren't horribly traumatized. It didn't reach that level for multiple different reasons, but it keeps building so that the next thing is not too far from the last inappropriate thing. And so it's not a big leap. And as you move up the scale, it's easier to keep the child cooperative and engaged in the process. I just spent 20 minutes trying to explain that to a jury yesterday, so they understood why the child didn't run away, why the child kept going back to uncle's house, and why those kind of things were not. When we work with offenders in a system, this is what we do briefly. This is like a whole day kind of training, but we make them write responsibility letters. It is my fault that I molested you, and I want to take total responsibility, and I lied to you, and I did things to make it possible, and you have no responsibility, and none of this has to do with you. And that's a huge message that has to get out. And as a therapist of an offender, it takes multiple times to write those letters. If the letter gets really good and they finally get it down, and I work with the victim's therapist, we then may share that letter with the victim. And I think it's a good part of the therapeutic process. If we're thinking about reunification, or even sometimes in other systems, we may end up with a responsibility meeting where we have the victim and their therapist, the offender and their therapist, and possibly a third mediator. And we do a responsibility meeting where the offender says, I'm sorry, and I did this, and I was wrong, and I want you to understand that. And it's the responsibility of the offender's therapist to grab him by the arm and move him out of the room instantaneously if he violates any of that, taking full responsibility. Then we can develop safety plans. We can get therapists through long periods of treatment. My recidivism of my 15, 16, 17-year-old sex offenders after 2 years of treatment, followed up 3 years after they completed treatment. Treatment was 2.7%. And that was for any arrest, not just for sex offense. So I can tell you that I felt comfortable putting adolescent young men back into a family where the molest had happened after they completed the treatment process. And people think I'm crazy sometimes, but I think at times there are ways, but there are an awful lot of caveats and criteria to that comment I just made. I think couples counseling is really helpful in this process. And finally, family therapy. Voila. I made it. I would take a look at these websites. This is Dr. Bruce Perry, the Trauma Institute. Dr. Perry was at Columbine in Waco, Texas, at Columbine in Colorado, at the Branch Davidian event. I was lucky enough to co-teach with Dr. Perry for 3 years for the Attorney General's office in the Safe from the Start program a number of years ago. We trained 6,000 law enforcement officers how to do a better job with interviewing kids in domestic violence homes. ABSEC does tons of wonderful training. Their next live training will be in December in New York. Dr. Briere's website, tons of free stuff there. If you want to learn about PCIT, this is their website, and PC Cares. Dr. Bessel van der Kolk is one of our leading figures in trauma theory, does tons of trainings. Some of it's available on DVD, online. Sign up for the National Child Trauma Stress Network. They send you tons of stuff. It's great. In connection with Cal OES, we're doing training with CIR in the CATA Center. We're pumping out lots of trainings, and it's all available to you in consort with this. And if you're more interested in ACEs, I would go to the California ACEs Academy. They're doing more and more trainings. They're doing some really exciting stuff. So those are some resources for you. I'll leave that up for a little minute, and I'm going to turn it back to Melissa.
Thank you so much, David. This was a wonderful presentation. And as promised, I was monitoring the chat for any questions that were fielded for you. So I have a few that came in that I wanted to ask quickly before moving into our debrief session. And the first question that we had was from Celine. She was hoping that you can explain more about what establishing a baseline of distress in all areas looks like. How do you do that, and what does it look like?
Yeah, basically use 2 or 3 of the trauma instruments that I talked about earlier, and they measure different areas of trauma. I like using PEARLS or the ACEs because they actually they identify different traumas that have gone on. And so we're talking about what were the traumas that this child has experienced? So we're looking at things, but then we're looking at valence. In other words, if you were in a domestic violence home for 4 years as a child, it's very different than if your parents got in this terrible fight and your dad hit your mom against the wall and it was the first time you'd ever witnessed that kind of experience. So exposure levels, length of times of exposure, the types of things you were exposed to, the type of things that happened in your life that went on. And interestingly enough, with child sexual abuse, we actually have partial or complete amnesia to sometimes being molested or what the molest was like or what happened. So some of this comes out as we trigger things during the therapeutic process. Dr. Briere really established that really well. So I would say it looks like what, and there are 4 or 5 different instruments to what were you exposed to, how long did it go on, and talk about the intensity. Obviously, there are different types of traumas in terms of the grievousness of that trauma. So that's some of the things I'd look at. And it continues to be added to as you do therapy, because more and more things get talked about, more things get attributed. People feel more comfortable being honest about going on. And so I keep that up. I keep that sort of list of things constantly going. That's a quick answer.
Perfect. Thank you. And then I'm just going to highlight one last question before moving into our breakout sessions. And the question is, what resources do you have for adult victims of sexual abuse who did not deal with the molestation until an adult?
TFCBT still works a lot of parts of it. CBT works with a lot of it. If we got a lot of symptom issues, we work with it. But my bottom line answer is we need to find a way to get people in to see a highly trained child trauma and adult trauma therapist. I think trauma-based therapy is where we're going. And I know that some people think we've overemphasized it in the last few years, but I can't go another way. We in our clinic see a lot of adults who come back. When we do marriage counseling that are having sexual problems, childhood trauma is one of the underpinnings of an awful lot of sexual problems people have in adult relationships. So my answer is find a good therapist who's trauma-based, who's using those strategies, get a good assessment for that adult where we reach all the way back, and some of the ACEs assessments are really good in that area. And then we move forward in a trauma-focused kind of therapeutic healing process. And that's sort of the best I can say for there. Thanks, Melissa.
Perfect. Thank you so much, David. And David will stay on this meeting. So if there's any other questions that you had, you could always request for him to join your breakout session. So at this time, I dropped some of the debrief questions that were prepared by our advisory committee. And I've already created the breakout room. So we're going to take just a few minutes to reflect a little bit more deeply and think about how this applies to your work and how you might shift your perspective or your practice given everything that we've heard today.